Good. All right. Hi, I'm Jihi Cho. I'm a breast imaging radiologist at Brigham and Women's Hospital. I'll be discussing overview of breast imaging today. So the goal of breast imaging is to detect breast cancer early. Early cancer detection allows more effective treatment and it can reduce breast cancer-related deaths. And the main three imaging modalities that are available to evaluate breast cancer are mammogram, MRI, and ultrasound. And I'll go over each one a little bit more in detail and also briefly discuss about contrast enhanced mammogram at the end of the talk. So mammogram is an X-ray that is specifically designed to take image of a breast, and it plays a key role in breast cancer screening. There are multiple observational studies of screening mammogram that showed that there are 30 to 40% fewer deaths due to breast cancer among women screened with a mammogram compared to women who do not undergo screening. So there is really good benefit of getting screening mammogram every year. I'm just going to explain what it means to be called back from screening mammogram. So out of every 100 women who get screening mammogram, about 90 will be told that their mammograms are normal, and 10 will be asked to come back for additional imaging, usually another mammogram and or ultrasound. And among those 10 people, 1 or 2 will end up needing a biopsy. And about 25% of biopsies will turn out to be cancer. Just wanted to point out these numbers as additional imaging and a biopsy can cause anxiety. And however, only a small number of people who get called back from screening mammogram end up being diagnosed with breast cancer. And that is because we're looking for all these signs of breast cancer, and this can be very subtle on imaging. So what are potential signs of breast cancer on mammogram that radiologists are looking for? So the cancers can present as mass, calcifications, architectural distortion, or focal asymmetry and asymmetry. I'm mentioning these terminology as you may see these on your mammogram report. And we also use terminology questionable on our screening mammogram report as we really need additional imaging to clarify whether these signs are truly present. You may also see breast density on the report. So breasts are made up of a mixture of fibrous and glandular tissue and fatty tissue. And breasts are considered dense if they're more fibrous or glandular tissue than fatty tissue. And radiologists classify breast density using a full level density scale. Sorry, I'm gonna just mute my email. Okay, sorry about that. From almost entirely fatty to scattered areas of fibroglandular density, heterogeneously dense, which may obscure small masses, and extremely dense, which lowers the sensitivity of mammogram. So dense breast tissue is prevalent among women, but what does that mean? So dense breast tissue, there are a couple of implications. Dense breast may make it difficult for radiologists to spot cancer on mammogram because dense tissue appear white on mammogram, and non-spot benign and cancer also appear white. So mammograms can be less accurate when a woman with dense breast with decreased sensitivity by 50 to 80%. Another implication of having breast dense tissue is increased risk of breast cancer. So just to put things into perspective, these are the numbers and the data. The risk in women with extremely dense breast, there was a fourth category on the prior slide, has been reported approximately 4 to 6 times greater than that of women with almost entirely fatty breast of the first category of density. Compared to the scattered fibroglandular density, which is the second category, heterogeneous dense tissue, third category, confers about 1.5-fold risk, and extremely dense tissue, the fourth category, about a 2-fold risk. So what are some ways to overcome decreased sensitivity of a mammogram with dense breast tissue? So digital breast tomosynthesis is a newer technique of mammogram that was FDA approved in 2011. It's also called 3D mammogram in a lay term, compared to a traditional mammogram, which is the digital mammography, or 2D mammogram, which creates 2D-dimensional images of the breast. So 3D mammogram basically take multiple images of the breast from different angles and reconstruct it into a series of stacked images. And these stacked images really improve lesion characterization by radiologists, and it can improve cancer detection rate by 1.2 to 4.6 per thousand mammogram that's been obtained compared to 2D alone. And this increase in cancer detection rate was seen across all breast densities due to improved lesion conspicuity. Recurrent rate, which is a rate of being called back from screening mammogram, are also lower with tomosynthesis or 3D imaging. Decrease in recurrent rate range from 15 to 17%. And 3D imaging tomosynthesis is more likely to find invasive cancers with features that are associated with a better prognosis, which are well differentiated, smaller size, estrogen receptor positive cancers, and node negative cancers. So the limitation of tomosynthesis or 3D imaging is increased radiation dose. So the radiation dose of getting 2D plus 3D increases up to 2.25-fold compared to getting a 2D alone, but still it's well below the federal limit of radiation dose. So in response to concerns of increased radiation dose, synthetic mammogram has been developed. So synthetic mammogram is basically a 2D images that are reconstructed from the tomo imaging without taking an actual 2D imaging. So whenever a woman gets a 3D mammogram, synthetic mammogram is automatically created. And the question is, can that be substituted for the actual 2D imaging? And the radiation dose using synthetic mammogram from 3D imaging is comparable to getting a 2D only. And there were similar outcomes in terms of cancer detection rate and recurrent rate of using synthetic mammogram only without getting an actual 2D imaging. So at our institution, tomosynthesis is standard of care for all mammograms that are obtained. For screening mammogram, we obtain 3D imaging with synthetic mammogram without actual 2D imaging, except for women who are getting their first mammogram at our institution and where it's been a long time since the last mammogram. And all the diagnostic imaging are obtained with both 2D and 3D. I'm going to move on to MRI. So this is a picture of MRI, magnetic resonance imaging machine. It's a large tube machine that uses strong magnets and radio waves to create images. And for breast MRI, patient lies on a table facing down with the arms above their head, and the breasts are placed through the openings in the table. And MRI performed for breast cancer detection requires use of contrast, which is injected into a vein. Okay, so the safety profile of MRI, there's no radiation exposure that's involved with the MRI. MRI uses strong magnets, therefore certain precautions must be taken in people who have implanted devices. Those will be a screen prior to coming for an MR exam. Papa during pregnancy, so there is no evidence to suggest that MRI is harmful to the fetus. However, the use of MRI contrast, which is needed for the cancer detection, is contraindicated during pregnancy. And MRI contrast deposition has been reported, but the clinical importance is unknown. And at this point, FDA concluded that the benefit of MRI contrast continues to outweigh any potential risk. So there are many different indications of getting breast MRI, and one of the main indications is breast cancer surveillance for women at high risk for breast cancer. So American Society of Cancer provided an update of its screening guidelines in 2007 and recommended use of MRI in conjunction to mammogram in high-risk patients that's defined as having more than 20% lifetime risk of breast cancer. MRI can find some cancers that are not seen on mammogram. The data shows that the average sensitivity of MRI imaging in high-risk women is around 95%, with MRI yielding additional 16 cancers per thousand examined, in addition to cancers that are detected on screening mammogram. However, it is also more likely to be recommended for follow-up examinations and or biopsies for findings that turn out not to be a cancer. So therefore, MRI breast is not routinely performed for women without any risk factors. The specificity of breast MRI, it's pretty, and there's a wide range in the literature from 56 to 98%. So this is just an example of breast MRI imaging showing a breast cancer that's detected on the MRI for a woman who came for breast cancer surveillance MRI, for women with a high risk of breast cancer. So women with the significant factors that increase their risk score above a designated threshold, more than 20% lifetime risk of breast cancer, have a well-defined screening guidelines of using a breast MRI as an adjunct to the screening mammogram. How about women with intermediate risk? So in previous recommendations, the recommendation for use of MRI in women of intermediate risk, as defined as 15 to 20% lifetime risk of breast cancer, were uncertain. For example, these women included the woman with a personal history of breast cancer, woman with a lobular neoplasia or ATPI biopsy, or with dense breast tissue. There are now newer data that are available to clarify use of MRI in this population. So women with high risk lesions, the American Society of Cancer does not recommend for or against screening MRI in patients with lobular carcinoma in situ, LCIS, atypical lobular hyperplasia, ALH, or atypical ductal hyperplasia, ADH. More recently, the guidelines from American College of Radiology recommended consideration of MRI for this population, particularly in the presence of other risk factors, and also supported by 2017 National Comprehensive Cancer Network guideline. So one of the recent breast MRI study of women with LCIS, ALH, or ADH showed that the overall cancer detection rate by MRI was additional 12.4 cancers per thousand examined. And when they looked at more closely, they saw more MRI detected cancers among women with LCIS compared to ALH or ADH. About women with a dense breast tissue. So dense trial is the biggest biggest study that's been that looked at the use of breast MRI for women with dense breast tissue. It is a multi-central trial in Netherlands for women who have extremely dense breasts, and they were randomized to a group that were invited for screening MRI versus a control group who only underwent screening mammogram only. And these are the data. So cancer detection rate was 16.5 per thousand during the first round of screening MRI. And on the second round of MRI, the cancer detection rate was 5.8 per thousand. And this reduction in cancer detection rate is not unexpected, as a lot of cancers that were not seen in mammogram alone were identified more within the first MRI examination. And this reduction in the incremental cancer detection rate by MRI from the first round to the second round occurred alongside with a pretty marked decrease in false positive rates in the second round of 26.3 per thousand compared to almost 80 per thousand during the first round. So the future directions of a breast MRI, the abbreviated MRI is basically a shortened version of a standard MRI, which can reduce costs and increase availability as we have more clinical evidence that's growing, supporting the performance of screening breast MRI in larger population of women. At this point, it is in the clinical practice, but in many places, but it's not approved by insurance at this point. And another technique that's being investigated and not in clinical practice yet is a non-contrast MRI for cancer detection with the technical diffusion weighted images. So I'm gonna next talk about the use of ultrasound, which uses sound waves to image the breast. There is no ionization radiation that's involved. And the indications for ultrasound is to evaluate symptoms, non-calcified lesions in a mammogram that's more kind of focused in one area. And then we use ultrasound for breast cancer screening for women with dense breast tissues. So whole breast ultrasound is a supplemental screening exam that's designed for women with dense breast. And studies have shown that there additional 2 to 4 cancers that can be detected per 1,000 performed. However, the additional cancer detection was achieved at the expense of a higher false positive interpretations. So the initial randomized multi-center trial investigating the utility of screening breast ultrasound was ECRN 666 trial. And the results show that the addition of ultrasound to screening mammogram detected additional 4.2 cancers per 1,000 during the first year. And years 2 and 3, the additional 3.7 cancers per 1,000 were detected. And the specificity of combined mammogram and whole breast ultrasound was 74% in the first year and then increased to 84% in years 2 and 3. What's important to understand about this study was that the patients were not only that have dense breast tissue, but they also were high risk with at least one additional risk factor. So the studies confirmed that the addition of ultrasound to mammogram in women with increased breast density and also with the increased risk of cancer resulted in a substantial increase in detection of mammographically occult breast cancer. However, the question still remains as to what's the impact of screening breast ultrasound in women in dense breast tissue without any additional risk factors. So as states began implementing breast density notification laws, there was which require women to be notified of their breast density. There was increasing use of supplemental whole breast ultrasound, screening ultrasound in asymptomatic women with normal mammograms and dense breast tissue. And Connecticut was the first state to pass the notification law in 2009. So one of the kind of earlier studies looking at whole breast ultrasound in Connecticut studied women who received whole breast ultrasound, and 75 of them had weak and no known risk factors. And first year, they looked at cancer detection rate was 3.2 per 1,000 during first year, kind of similar to the last study that I talked about. And all cancers were smaller than 1 centimeter and no negative, and a positive predictive value was pretty low, meaning the percentage of cancers detected among lesions biopsies, so specificity was pretty low. But at the year 5, the cancer detection rate was still remain relatively similar, 2.6 per 1,000, but positive predictive value increased to 25%. And less follow-up was recommended as years go along. So whole breast ultrasound can be performed in 2 ways, handheld and automated. The handheld whole breast ultrasound is performed by a physician or ultrasound technologist using a handheld ultrasound probe. The limitations of handheld whole breast ultrasound includes that it's operator dependent and it lacks reproducibility, can be time sensitive and requires specially trained staff. To overcome that limitation, automated whole breast ultrasound was developed, which uses a machine and which performs the examination with the ultrasound probe through an automated process. And if any abnormalities are found, then a handheld ultrasound is then performed to further evaluate the machine's finding. And the results show that the handheld and automated whole breast ultrasound have comparable cancer detection rates and sensitivity and specificity. So just wanted to also point out that the MRI is more sensitive than the combination of mammo and ultrasound. So women who qualify for screening MRI should have MRI instead of screening ultrasound if they have access and are able to tolerate MRI. And when MRI is performed, then screening ultrasound has no added benefit. All right, lastly, I'm going to be briefly discussing the contrast enhanced mammogram, which is an emerging technique that uses iodinated contrast. And iodinated contrast, it is the one that's being used for CT. So the contrast is injected into a vein, then the mammogram is taken. It's been approved as a diagnostic tool since 2011 and shown to have high sensitivity and specificity compared to MRI in terms of its role as a diagnostic tool. And its role as a screening tool is still kind of investigated. The studies have been shown that cancer detection rate is 13 to 15%, 13 to 15 per thousand in high risk and intermediate risk women. But there were more false positive findings than conventional mammogram. So benefits of contrast-enhanced mammogram is that it can be obtained in women with contraindications to MRI, and it's less expensive than MR. But it can have potential reaction to, people can have potential reaction to either in a contrast, which can be from mild to severe, and there can be additional radiation dose as well. All right, these are my references. And I'll take questions and comments at this point.
Thank you very much for that nice overview. We do have one question in the chat. Is synthetic mammography recommended over 3D mammography for women with dense breasts or a family history?
Yeah, so that's a really good question. Just to clarify, synthetic mammogram is part of the 3D. So synthetic mammogram is reconstructed from the 3D imaging. The question is, do we get additional 2D imaging in addition to synthetic mammogram? So synthetic mammogram is part of the 3D imaging.
Great. And maybe you could just share a little bit about the services offered at the Brigham. What type of mammography do we do at our sites?
Sure. So at Brigham, we do 3D imaging for every woman, whether it's a screening mammogram or diagnostic mammogram. And in terms of getting a 2D imaging, like I said, for screening mammogram, routinely 3D imaging is done with just a synthetic mammogram, unless it's the first time the woman's getting a screening mammogram in their life or at our institution, then we do 3D and 2D imaging. And if it's been a few years since the last mammogram, we also want to get 3D and plus 2D imaging. And for diagnostic mammogram, you always get 2D and 3D.
Okay, I want to talk a little bit about the MRI use, because we in our clinic, one of the things we do is we really try to, again, personalize our recommendations for enhanced screening, because as you said, all these additional tools, they do have limitations. So none of our imaging is perfect. The goal of imaging, of course, is to detect cancer at an early stage. But some of the imaging modalities are associated with what we call higher false positive rates. And that was pointed out with MRI as well as ultrasound. And so we do, we look at the risk factors for each individual woman, and we try to make those recommendations for screening, weighing the risks and the benefits of these modalities. You touched on the high risk lesions and lobular carcinoma in situ in particular. And this has been an area of controversy, I guess, in the literature. Should all women with these high-risk lesions be having MRI or not? And although there are certainly studies, as you suggested, that show higher rates of cancer detection, our group has actually just published data from our own program, women with high-risk lesions, some of them having MRI and some of them not having MRI. And actually the cancer detection rates in our group are actually equal. And certainly the women having MRI are subject to more biopsies in their follow-up, in their surveillance period. So again, we think it's really important to have a personalized conversation about the risks and benefits of these additional tools. And certainly in some women, they are absolutely indicated, women who are at genetic risk for breast cancer, which again, we're going to hear about in the next talk. We certainly know that some of those cancers don't show up well on our standard imaging. And so we do need MRI in women who are at inherited risk. But again, not everyone can have an MRI, and it is an expensive test. If there's any metallic implants, women can't have MRIs. And claustrophobia is a big problem for women. So looking at new modalities such as the contrast enhanced mammography that you mentioned briefly is really important, because as you said, the emergent studies show that the sensitivity or the likelihood that a contrast enhanced mammogram will find a cancer is really quite similar to the data from MRI. And so we've been, hoping and working for several years to think about getting contrast enhanced mammography into our program at the Brigham. And we do have a question about that in the chat. So I am happy to say that it is coming. We are working on getting contrast enhanced mammography units at our Brigham and Women's Faulkner Hospital Screening Center, as well as at our Dana-Farber Chestnut Hill location. So we are very hopeful in the next 1 to 2 years, hopefully closer to 1, that we will have contrast enhanced mammography up and running at both of those sites. So one more question that has come into the chat. How often would you recommend other imaging besides MRI for heterogeneously dense breasts, for women with heterogeneously dense breast tissue? What are the screening recommendations for that group?
So if there is no other risk factors, I think whole breast ultrasound is a good modality as a supplemental screening tool. Obviously, if there's any other risk factors that increase the risk of breast cancer more than just having dense breast tissue, I think MRI will be useful depending on the number. But if without any risk factors, I think whole breast ultrasound will be beneficial.
And can you tell us, for our patients who are local, who are on where our group offers whole breast ultrasound?
Yeah, so at our institution, the whole breast ultrasound is a handheld whole breast ultrasound at this point that's offered at Foxborough location. And we offer whole breast ultrasound in the area, and it's a live read, so the technologist will scan, but there will be radiologists on the site if there are any questions about any findings that are being scanned by the technologist.
Great. And, one of the things that's changed recently is for many, many years, women were used to coming in and having their mammogram and getting their results right away. And now the trend has shifted where women are getting their results a day or two later. And we get a lot of questions about this. Can you explain really why the increased value of you all being able to take your time and really look at those images and not giving the report right away?
Sure. So, so there has been studies looking at the kind of efficiency and accuracy of radiologists interpreting the mammograms when we're doing live read versus reading mammograms in a batch. And the studies show that it's actually the performance was better when you're reading the mammograms in a batch without any interruptions. That's why we moved to kind of getting rid of what we call it offline mammogram, meaning the woman come in and leave and we read those kind of in a couple of hours or a day later in a batch and give the results. And that performance has been shown to be better in that situations. That's why we moved away from live read and for a better accurate read.
Yeah, and I think that's a really important message because we certainly understand that there can be some anxiety associated with waiting for your result from your mammogram, but the data really do show that the accuracy of the read is better, again, when the radiologists are able to, sit and read and not be interrupted, coming back and forth, from one patient at a time. So again, we appreciate that it's harder to wait, but it is for a good reason that we've shifted to that. So, all right, well, not seeing any other questions in the chat. So I want to thank you, Jahi, for a really nice overview.